Hi guys, let's discuss about beta thalassemia today. Before discussing about beta thalassemia, let's get to know the classification of hemolytic anemias. We classify hemolytic anemias into hereditary and acquired types. In hereditary, we have red cell membrane defect, red cell enzyme defect, and hemoglobinopathies. In red cell membrane defect, we have hereditary spherocytosis, elliptocytosis, and A beta lipoproteinemia. In enzyme deficiency, we have G6PD deficiency, pyruvate kinase deficiency, and hexokinase deficiency. In hemoglobinopathies, we are going to discuss about thalassemia today, which is a quantitative hemoglobinopathy, and sickle cell disease, which is a qualitative hemoglobinopathy, and unstable hemoglobin disease. In acquired variety, we have autoimmune hemolytic anemias due to warm antibodies that are idiopathic and secondary, due to cold antibodies, cold agglutinin disease and paroxysmal cold hemoglobinuria, and hemolytic disease of newborn. And fragmentation syndromes like hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, disseminated intravascular coagulation, and prosthetic cardiac valves. And miscellaneous like drugs, chemical injury like snake bite, lead, physical injury like burns, infections like malaria, kala azar, hypersplenism, and paroxysmal nocturnal hemoglobinuria. Coming to beta thalassemia is one of the inherited hemoglobinopathy due to monogenic globin gene defect, which is autosomal recessive in inheritance. Here, there is defective synthesis of the beta chain of hemoglobin, mainly hemoglobin A. Because hemoglobin A is made of alpha 2, beta 2, here there is a defective beta chain synthesis. It is also called as Mediterranean or Cooley's anemia because this is more common among the Mediterranean region. You can see the pathogenesis here. There is defective beta chain synthesis, but alpha chain synthesis is normal, so there is excessive alpha chains which forms insoluble aggregates, and this is the one that is mainly involved in the pathogenesis of hemolytic anemias, because this excessive alpha chains that will initiate the hemolysis to occur. So we can see here microcytic hypochromic RBCs that undergoes destruction in the spleen, causing extravascular hemolysis due to ineffective erythropoiesis, leading to anemia. And because of anemia, there is hypoxia and increased EPO, erythropoietin production. So there is medullary and extramedullary erythropoiesis. This can be manifested in the form of bone marrow expansion leading to thalassemic phases and hepatosplenomegaly. And this requires blood transfusion, and due to blood transfusion and also because of increased iron absorption leads to hemosiderosis, that is hemosiderosis and hemochromatosis due to iron overload. We'll see the spectrum of beta thalassemia. In beta thalassemia, we have three spectrums. One is beta thalassemia major, the other is beta thalassemia intermedia, the third one is beta thalassemia minor, also called as beta thalassemia trait. Here, beta thalassemia major, it is a homozygous disorder. Either there will be no production of beta chain or a markedly reduced production of beta chain. If it is a no production, it is written as beta 0. If it is reduced production, it is written as beta plus. So this beta thalassemia major is a homozygous disorder. And beta thalassemia intermediate is a double heterozygous state, and beta thalassemia minor is a heterozygous state. Thalassemia major is the severe form where there will be severe anemia and it's also transfusion dependent. Whereas thalassemia intermediate is not that severe, it's a moderately severe anemia that does not require blood transfusion. Minor is asymptomatic with mild anemia. In beta thalassemia trait, HbA2 will be elevated, whereas in beta thalassemia major, HbF will be elevated. This is the spectrum of beta thalassemia. Next, we have clinical features. The child will develop severe anemia after 6 to 9 months of age, because before 6 months, the child will have HbF that does not interfere, because HbF has only alpha 2 and gamma 2. So there is no beta chain in HbF. Only after 6 months, the child starts synthesizing HbA. So since it requires beta chain, there is a defective beta chain that develops severe anemia. Sometimes the child will have persistent HbF even up to 3 to 5 years. So the child will be failure to thrive, and there will be growth retardation and susceptible for recurrent bacterial infections. And as we have already told, we can see some changes in the bone due to extramedullary hematopoiesis, medullary hematopoiesis, bone marrow hematopoiesis, where there will be bone marrow hyperplasia that will be manifesting in the form of thalassemic phases called the chipmunk phases. You can see the characteristic chipmunk phases here, where there is frontal bossing and there is malar prominence and hypertrophy of the maxilla, and there is depressed nose bridge. This is the characteristic chipmunk phases or thalassemic phases seen in beta thalassemia children. And on X-ray, if we see, these are some of the crew cut or hair on end appearance that is seen, which is evident of medullary hematopoiesis, erythropoiesis that is taking place. And extramedullary hematopoiesis will be manifested in the form of splenomegaly and as well as hepatomegaly. And due to iron overload, this iron overload is because of blood transfusions and increased GI absorption of iron, resulting in the form of hemosiderosis. So it mainly affects the cardiac, hepatic, pancreatic and pituitary organs. In cardiac, it causes arrhythmias, heart blocks and CCFs. In liver, if it deposits, it leads to cirrhosis. Pancreas, it causes diabetes, and pituitary, it causes hypogonadotrophic hypogonadism. These are the clinical features of beta thalassemia major. Next, we have investigations. In investigations, first we will do complete blood count that shows hemoglobin that is reduced, and mean corpuscular volume and mean corpuscular hemoglobin will be reduced. And mainly we will come to the peripheral smear. In peripheral smear, if you look at the RBCs, they are microcytic and hypochromic, and some cells are varied in shape, leading to anisocytosis. And the characteristic finding is this target cell. What is a target cell? Target cell is one that has a central dot-like structure. So this is the condensed hemoglobin that is present in the center. This is the characteristic finding of a thalassemia. And regarding platelets, there may be thrombocytopenia once if there is a hypersplenism. And the main thing is reticulocyte count. There will be reticulocytosis because of accelerated erythropoiesis. And we can confirm the diagnosis with the help of HPLC, high performance liquid chromatography, and hemoglobin electrophoresis, where the HPA will be absent because defective beta chain synthesis, and instead there will be high levels of HPF if it is a beta thalassemia major, and there will be high levels of HPA2 if it is a beta thalassemia minor. Coming to the treatment, they require blood transfusion repeatedly every 4 to 6 weeks. And due to this repeated blood transfusion, there are some complications like transfusion reactions, febrile reactions, allergic reactions, and blood-borne viral infections like HIV, HCV, HBV. And one peculiar complication is this lactoferrin activity will be diminished because of these transferrin saturation, very high transferrin saturation, leading to infections peculiar like Yersinia enterocolitica, mucormycosis, and Listeria monocytogenes. And they also require long-term folic acid supplementation and avoidance of iron-containing foods because there is already iron overload. So in order to manage the iron overload, we have iron chelation therapy in the form of desferrioxamine in subcutaneous infusion pumps at a rate of 60 mg per kg per day over 12 hours for 6 days a week, or other oral forms like defracirox and defriprone. And only in hypersplenism and massive splenomegaly, splenectomy is indicated. And if we do splenectomy, we will have to do prophylactic antibiotics and also some vaccines against capsulated organisms like pneumococcus and Haemophilus influenza. And the main curative treatment of this thalassemia is hematopoietic stem cell transplantation. And for prevention, we have to give genetic counseling and prenatal testing. And other drugs for just the beta thalassemia intermedia we can give is hydroxyurea, where it stimulates the synthesis of more HPF, so it relieves recurrent blood transfusions.